In this video, I will be describing the clinical characteristics of COVID-19. I'm going to share some opinions that are based on my experience as an infectious diseases specialist, based on a review of the scientific literature and conversations with many fellow experts in the field. These are my personal opinions and may not reflect those of the University of Florida or UF Health. Let's return to the case of Dr. Cici. As you recall from the first video, Dr. Cici was a 30-year-old gastroenterologist and married mother of a 2-year-old son. She was exposed to the virus while taking care of a 76-year-old woman with COVID-19. We have no details on whether she used personal protective equipment, PPE, but we can say her infection control technique was ineffective. And this is a warning for all caregivers, and we will discuss the use of PPE in the final video. 5 days afterwards, a typical incubation period for the virus, she experienced marked fatigue, followed quickly by fever and chest tightness. She did not complain of a cough. On arrival to the hospital, she was noted to be hypoxic, and it is likely she had been experiencing shortness of breath. On day 6 of her hospital course, she was improving. Her fever resolved. However, her oxygen exchange failed to improve. It is likely that her alveoli continued to be filled with fluid, and over the remainder of the hospital course, the walls of her alveoli became fibrotic, interfering with alveolar oxygen transfer to the arteries. This condition, in all likelihood, explains her progressive deterioration from the hospital day 7 through day 34 and her cardiac arrest on day 35. As an infectious disease expert, I like to create an illness script for each disease I encounter. This script consists of 4 components. 1, epidemiology. Important questions to ask for this disease are, in the last 10 to 14 days, did you travel to a region with a high incidence of COVID-19? Did you participate in a large gathering or take a cruise? Were you exposed to someone who had symptoms suggestive of COVID-19? Pace of illness. How quickly did your symptoms come on? Acute disease develops over 12 to 48 hours, subacute over 3 to 10 days, and chronic over weeks to months. In most cases of COVID-19, the onset is acute to subacute. 3. Key symptoms and signs. The 3 most prominent symptoms are fever, a persistent dry cough, and shortness of breath. Finally, past medical history. For patients who may have COVID-19, we want to know if they have other chronic diseases because these patients have a higher mortality. This graph summarizes a study of 1,099 cases of COVID-19 from China. There are 3 bars for each complaint. All of the cases represented medium gray, non-severe cases light gray bar, and severe cases dark gray. As you can see, nearly everyone has a fever defined as a temperature of greater than 37.5 or 99.5 Fahrenheit. The CDC has a higher definition for fever, 38 degrees centigrade or 100.4 degrees Fahrenheit. I favor the lower definition. On arrival to the hospital, 1/3 of patients may not have a fever. However, most will have a history of feeling feverish. The second prominent symptom is a dry cough, found in over 2/3 of cases. Patients early on do not bring up sputum, but in about 1/3 of cases, the cough does become productive. The third symptom is most worrisome, shortness of breath, suggesting fluid is beginning to fill in the alveoli. This complaint is present in 15% of mild to moderate severity disease and observed in 37% of patients with severe disease. Fatigue and myalgias, also called muscle aches, are other prominent symptoms. Headache is moderately frequent, while diarrhea and vomiting are less common. In the Chinese CDC reports, chest tightness was observed in 30% of severe cases, and sputum production was found to be more common in severe cases. Laboratory findings include a depressed lymphocyte count, 87%, reduced platelets, 30%, and an elevated C-reactive protein, abbreviated CRP, 86%, a measure of inflammation. Chest X-ray is abnormal in 60% of patients. Chest CT is preferred and is more sensitive, identifying abnormalities in 84% of cases. It should be emphasized that CT scan may identify abnormalities even in mild cases. In severe disease, 96% of patients have abnormalities. Findings include a ground glass appearance in one lung field, right-sided infiltrates being more common. This can progress to bilateral ground glass appearance and subsequently to dense consolidation. Diagnosis is made by polymerase chain reaction of a swab of the posterior pharynx or throat. This test is highly specific, 98 to 99% specificity. The sensitivity is difficult to estimate because the sensitivity depends on the sampling method. The best PCR test can detect as few as 10 copies of the virus. Because of the limited availability of the PCR tests in the U.S., elaborate algorithms have been designed to decide who should be tested. In my view, this approach should be abandoned as soon as possible, given the finding that for every one symptomatic case, there are at least 8 people walking around with symptoms or minimal symptoms who are carrying the virus in their nose and have the potential to transmit the virus. We should be screening all people in areas where a symptomatic patient has been identified in order to isolate the other 8 people who have the potential to infect others. This was the approach used in South Korea and Singapore. As I showed in the last video, Singapore has had only a few cases, and recently the South Korean epidemic curve has flattened. As of March 17th, South Korea, population 51 million, had performed 274,000 tests as compared to the U.S., population 327 million, who had performed 25,000 tests. To achieve the same per capita testing, the U.S. should have performed 1.75 million tests. No wonder we are not bending the epidemic curve in the U.S. For patients sick enough to require hospitalization, given our limited PCR testing, chest CT can be helpful. 7 radiologists in China were evaluated as to their ability to accurately make the diagnosis of COVID-19 using CT scan, and this test proved reasonably sensitive, 67 to 93%, and had high specificity, 93 to 100%. There was one outlier radiologist who only had a 7% specificity. This figure from the WHO shows the progression of illness. The average duration of hospitalization was 12 days, 11 days for non-severe cases, and 13 days for severe cases. Mechanical ventilation was required in 38% of severe cases. Mild to moderate disease make up 80% of all the cases, and mild cases rarely progress to death. Moderate disease and severe disease more commonly progress, and patients who are critically ill have a chance of dying of 22 to 62%. Critically ill patients may develop septic shock with organ failure. This syndrome may be associated with high levels of cytokines, including interleukin-6. In the New England Journal of Medicine series, death occurred in 1.4% of cases, with a 0.1% mortality for non-severe cases and 8.1% for severe cases. The case fatality ratio reported by the WHO was 3.8% in China. Case fatality is defined as the number of deaths per total number of patients with the disease. This percentage may be an overestimate because mild disease was not always recognized, lowering the denominator. The case fatality rate will also be higher where care is limited. Given these limitations, experts estimate that the case fatality rate is between 0.5 and 3.5%. To put this in perspective, influenza's case fatality rate is 0.1%. Therefore, the case fatality rate of COVID-19 is 5 to 35 times higher than seasonal flu. Mortality is related to the sex of the patient, men having a higher mortality than women, as do patients with chronic illnesses, specifically hypertension, diabetes, cardiovascular disease, lung disease, and cancer, as shown in this table. Mortality is also affected by age. Death is exceedingly rare below the age of 30 and begins to climb in those over 60, being 40% for ages 60 to 69, 8% for those 70 to 79, and 15.5% for those 80 or older. To summarize the clinical presentation of COVID-19, their elements of the illness script for this disease were epidemiology, a history of travel or contact with an infected person. Pace of illness is acute to subacute in onset. Key symptoms include fever, dry cough, and shortness of breath, as well as fatigue and muscle aches. Essentially, a flu-like illness. And past history of chronic disease is an important prognostic factor. Lab findings in this disease are nonspecific. There should be a low threshold for PCR testing given the 8-to-1 ratio of minimally symptomatic to symptomatic disease. CT scan shows ground glass opacification that can progress to consolidation. And CT scan is a sensitive and specific test for diagnosing hospitalized patients. 80% of the time, the disease is mild to moderate in severity, but this disease can progress to irreversible hypoxia and death. A higher mortality is seen in men, those 60 years of age or older, and those with underlying diseases. Overall mortality is 0.5 to 3.5% and is 5 to 35 times more deadly than seasonal influenza.